afterwards. And please, during this meeting, we want it to be very interactive. So type all of your questions on a Q&A chat box, and we are going to be very happy to discuss your questions during the session and in the end of the session. So this is our April's calendar. We are full of activities to all of you. We are very happy and very proud to present great speakers and very nice topics to all of you. So don't forget about Dr. Anderson's series, now with Dr. Diana Spicer showing a very nice live anatomical pieces for us. So this Friday, we are going to talk about AVSD. So please join us this Friday. And Dr. Volkan, he makes this very interesting discussion about ECGs. So the next one in English is going to be on Tuesday, the 6th of April. Please join us. After that, he's going to stop because of the holy month of Ramadan. And after that, he's going to restart in the end of May. We are very proud to support the Fetal Heart Society in this very interesting meeting about the fetal TGA. It's going to be next Thursday, April the 8th. So please join us on that. On April the 12th, Dr. Mary Cohen is going to talk about coronary artery abnormalities. So how we are going to be able to diagnose them on echo. And then on 19th of April, Dr. Norman Silverman is going to continue his anatomical, his series that correlates anatomy and echo images. This is very interesting. I'm sure all of you are going to enjoy. On the 19th of April, we are going to talk about tetralogy of Fallot. And then on the 29th of April, we are going to have a very interesting fetal cardiac interventions meeting with people, very, very good people from all around the world talking to us about their experience. So please join us. And now we are going to start with Dr. Gil Wernovsky and inviting you to the 27th of April to join us again, because he's going to talk about post-op of tetralogy of Fallot. Gil is with you. You are muted, dear.
I think "you're muted" must be the most used expression in 2020 and 2021, other than maybe mute yourself. I'm not sure, but thank you for that introduction, and welcome to the series. There may have been some confusion, so I am glad that those of you who joined for the 10 o'clock start are here. As everyone knows, these sessions are recorded and on our YouTube channel, as well as all of our previous webinars, some of whom have reached close to 10,000 views. Today, as this is GW and Friends, I'm really happy to introduce to you one of my new friends and colleagues, Dr. Yves Dudekem. Yves recently started at Children's National in September of 2020. He was educated by Belgian parents and graduated from the, I hope I say this correctly, Yves, the Université Catholique in Louvain, Belgium, and started as a surgeon in 1993. Was trained in cardiac surgery in Belgium and also in South Africa, Canada, and the United Kingdom. His career really took off as he began working at Royal Children's Hospital in Melbourne in 2003. He rapidly obtained the position of the Deputy Director of Cardiac Surgery, and he's now an established leading figure in pediatric cardiac surgery. He was appointed professor in the Department of Pediatrics, University of Melbourne in Australia. And as I mentioned before, since September, he's been with us in Children's National Hospital, Washington, DC in the USA. His clinical expertise is in basically everything, but valve repair and mechanical circulatory support, and particularly in single ventricle conditions, in particular the Norwood. And as I'm going to be talking about a little bit later, has really parlayed his clinical experience with a particular type of patient into really advancing the field of knowledge into patients with all forms of single ventricle, both with the Fontana operation, but I think what's really unique for a surgeon is not only focusing on the surgeons, but how the patients do over the long run. And to be able to do that with your clinical expertise in the ICU and then see how those patients do, I think is a repeating theme that we'll be talking about today. His clinical research is not only focused on single ventricle, which I'll get into in a second, but is also in tetralogy of Fallot, pulmonary atresia with VSD and MAPGAs, art surgery, aortic valve repair, Ross procedures, things along those lines. And he created the Australia and New Zealand Fontan Registry. I did include that. It's fontanregistry.com for any of you who would like to take a look at this. It's, I think it's probably one of the best examples of prospective data collection that we have in our field. He's the chair of this registry. He has a large research team. He has international collaborations. I could go on and on. He's published more than 350 papers, 7 million in grant funding. And I have to tell you, I haven't worked with him for 6 months, just a wonderful colleague, open-minded, technically gifted, and a really great colleague to have. So with that, I'll turn this over to Yves, and he'll teach us all how to do what he's done in 45 minutes.
Thank you, Gil. Should I share my screen? Yes.
That'd be the best way to start, I think. Yeah.
Okay,
that looks
good.
great. Thank you.
So Gil asked me, if you have a panel and you want to share something, what would you talk about? And I'd like, to share what has been a very important part of my life, which is clinical research and the way I got there. And these are a lot of little tips and tricks that I give to my trainee over the time. So these are my disclosures. And I will start. I don't want to brag about, but these are objective metrics. Age factor, number of publications. That's actually increased. I haven't updated that. And Exposcape, which is a website that gather information mainly based on publication and the numbers of quote, put me as the most productive academic surgeon nowadays. How did I get there? That was never a goal of mine. I just do research to answer a question that I have. To be honest with you, as an adolescent and young adult, I was attracted by art. I was living in Brussels. We were often going to spend the weekend in Amsterdam. And I don't go over the details of what we were doing on the weekend, but even with my friends, every time we went to Amsterdam, we went to the Rijksmuseum, see the Vermeer, going to the Van Gogh Museum, see the Piet Mondrian. But I had absolutely no gift for anything artistic, and art was so important in my mind at the time. So I took refuge in books. I've been an avid book reader, and I was a writer, and every time in my life, I thought one day I'll end up becoming a writer. So I'm a frustrated writer, and I guess I have this facility that when I'm on a blank page, I like to write, and I enjoy the mere act of, at the time, writing on a piece of paper and the scratching of the paper by the pen. And now I like the clicking of my finger on my laptop. Yes?
You've told me that I am allowed to interrupt them at times, so I'm curious,
yeah.
What's your favorite book, Yves?
I'll talk about my favorite book later on in the talk, actually. One of my most favorite book. So it's coming.
Thanks.
Okay. By the end. So a lot of the important time of my life, an important decision has been following split moment. One of the split moment was when I was a medical student. You were entitled to do research in the lab, and that would give you point to access to the specialty. So that's the only reason why I went to the lab. And I was studying liver regeneration, doing hepatectomy in rats. And I was collecting with greatest difficulty the urine of the rats to study the excretion in the urine of mucopolysaccharides during liver regeneration. I found out at the time of the publication of the abstract that there were about 2 other people interested by that research in the world, which is not a lot. But there was this evening where I had all the results and I had made my graphs. And then suddenly, it was at night, I was walking and I was realizing that I was the first one in the world to get this data. Maybe if there was a God somewhere, he knew, but otherwise I was the only being in the world knowing about this result. And it got me this tremendous excitement, and that forever sealed my interest in research. That started there. So in the lab there, one thing that I learned, it was interesting. Professor Lambert was an inspiration for me at the time. And he used to say, when you do experiments, especially if you do experiments in the lab, you're doing surgery, you're doing something important. You want to have an effect. Don't look at the p-value. It's like when you give drugs for chemo, you don't want to have a p-value that your survival is just good. You give it, and it has to have a massive effect. If it doesn't have an effect, it doesn't matter. So it taught me not to be obsessed about too much about the statistics, but look at the results. My mentor in my career have been mainly these two people. Tyrone David, who was the head of Toronto General Hospital, was a major inspiration for me at all technical aspects of the surgery. At the time, the most superb surgeon you could dream of. I saw him doing a Ross procedure, skin to skin, without effort or speed, in 1.5 hours. And everything was just perfect. Marc Deleval was an enormous inspiration and still is one of my mentors, and I'm still in contact with him. And he taught me about research, but how to look at a pediatric specialty, and I'll go into details about what he taught me. Tyrone David inspired me because when he did clinical research, he really asked himself questions, was stepping in the dark and trying to find a solution. So the one example that I can give you was, at the time, he was a superb valve repair surgeon. That is his main specialty. And not only aortic valve, but also in mitral valve surgery. And at the time, he was saying that mitral valve repair was a very good operation, apart from rheumatic heart disease, because he had published at the time in Circulation the results of his mitral valve repair. But in that indication, the rate of reoperation was too high. And so he veered away from doing repair from rheumatic heart disease. But then his specialty is long-term outcome studies, which he taught me. And on the long-term outcome study, he kept following these patients for another 20 years. And that has been published later, showing that actually, yes, the rate of reoperation after repair was higher than with the other repair, but then the survival of this patient was significantly better if they had a repair rather than a replacement. And so what it told me is you have to follow your patients for a long time to have the answers. And he's the only guy publishing now 30 years outcome after mitral valve repair and aortic valve repair. And then you have to be able to admit that you can be wrong. Even in this case for him twice, he thought, okay, I was wrong to do mitral valve repair in rheumatic valve disease. Then he's thinking, okay, I was wrong to be wrong. And actually mitral valve repair is good for rheumatic mitral valve disease. But there's so many surgeons who are doing clinical research who have the answers before they got the results. You should ask yourself the question, get your results, and then make your conclusions accordingly.
I'll add to that, Yves, that whole notion about recognizing that we can be wrong is just as important clinically as it is research-wise. And I think that's a great message for everyone that's on the webinar.
So another thing that it inspired me in recent times is that he's the Pope of an operation that bears his name, the David procedure, the reimplantation of the aortic valve sparing operation, which he pioneered at the time I was there in Toronto. And by the way, he said to me, he had invented a valve, the stentless valve. He said, don't ever put your name on an operation, because if you find out 15 years later that your operation is killing all your patients, then your name is associated to something horrible. So he always refrained to put his name on that operation. Everybody called it the David procedure, but he called it the reimplantation, which is fair enough. The thing that is irritating with Dr. David and may seem irritating is that when he publishes, he always publishes his own results. And so you look at he's heading a team. There's only Chris Findel, who's his right hand, his pupils, who's in the authorship. And I find it, a bit arrogant. I always publish, with all the members of the team in the authorship, and I'm not looking at just my operation. But then something happened that made me reflect, and that's the one. I don't know if you've heard about the ART trial, if you're a pediatric cardiac surgeon, but they compared bilateral versus single mammary graft. And they did a large randomized trial, finally, you would think. And the result was negative. they could not demonstrate that bilateral mammary was better than single mammary. I mean, everybody who's done a cardiopulmonary bypass and done multiple mammary bypass, as I did, know that it's better to do bilateral mammary grafting. But then if you look at the trial, you know, you had an enormous number of surgeons who barely did, you know, 50 bypass cases a year. And the crossover, the median crossover was close to 25%. So in 25% of the cases which were randomized to have a bilateral mammary, or there was a technical reason and the guy switched to a single mammary. So this whole trial is hopeless. So my lesson is that, you know, imagine the operation that he described, the aortic valve sparing procedures. We know today, he's shown with 25 years result, that this is an excellent operation. If you had done 15 years ago a randomized trial on that operation, that would have failed. He would never been able to demonstrate the benefit of this procedure. So if you have something that is technically challenging, you should never do a randomized trial. If it's depending on the technique. Aortic valve repair, I know that aortic valve repair is superior to, you know, balloon dilatation in a lot of intervention. I know that it's a good operation for bicuspid aortic valve in children. I will never do a randomized trial for that because it's technique dependent. I will show my own results, but not do a randomized trial. Do you want to comment on that, Gil?
No, not at all, especially as you go across multiple institutions that not only have technical differences, but perioperative, intraoperative differences as well.
Yeah, so randomized trial is not everything. It has its use if you want to test something in the real world, but you don't have to do a randomized trial for everything. Marc de Leval was the inspiration behind the physiology of the fontan circulation, and he described the lateral tunnel in the 80s. He was amazing, you know. When I was in training in '98, he showed me an abstract he sent to the ATS, and then it was a lot of, I could not find this abstract. I don't know if it was ever published, but it was a lab experiment on the animal with some dosage. And you can see the kind of abstract you read in, you know, the NKT F5-100 give rise of the interleukin systemic stuff and so. And then he put the conclusion, and then he said, there's a correlation with this, and so you should do the fontan earlier. I said, how can you get to that, jump to that conclusion? I said, you know, in an abstract, you have to sell your stuff. So, you know, don't hesitate to make jumps. And I think that was for writing, that was a very useful tip that he gave me. You're telling a story, sometimes you have to push it a little bit to make it attractive, especially in an abstract for a paper.
It's interesting how you and I haven't prepared this together. In the second half of this webinar, I'll be talking about how to write abstracts. You may be doing it as well. But I hope that people can stay on as well as we start to put some tips out and field questions about how to get abstracts accepted, what to put into a 10-minute talk. I certainly would love your impressions on that if you haven't included that already.
And so the remarkable feature of the career of Marc de Leval is how he looked at his own results. This story is very well known. At the beginning of the, you know, a few years after the beginning of the experiment with the arterial switch, he had a cluster of death. And so he expressed that in this graph where you can see the mortality, and suddenly it increased. So it counts with time the number of death happening. And so he asked himself the questions of why it would happen. He retrained himself by going and observing Bill Braun at the time. And he was very genuine about it and candid and presented, which is absolutely exceptional in our discipline. And then he pursued the study by doing a human factor study. He associated himself with James Reason, a major psychologist working in the aviation industry, to find how human error impact our judgments and the outcomes. And it's still a groundbreaking study in any kind of this field. So the things that he taught me is the absolute honesty in all you do, and being candid and being brave enough to get to the, you know, publicly about your own result and your own failure and speak out. And I invite you to read his book that is has been just published this last year. Interestingly, in that book, and I copied that, he mentioned the first time in 1859 where a head nurse started to look at benchmark analysis. And then that's the way he put, you know, the history, the first attempt of comparing results. And he said that in 1859, the dedicated nurse was wise enough to predict 3 of the major problems that continue to plague statistical analysis today: risk-adjusted outcomes, data manipulation, and the inadequacy of mortality as a single outcome measure. And I will go back to that with an example. It's amazing. That's 170 years we know that we should not be focused only on hospital mortality, and still look at what we're doing. A tip for writing and papers was given to me by a colleague at the time, Malcolm Underwood. He was a fellow trainee coming from Bristol at the time. He's now the head of Department of Cataract Surgery in Hong Kong. And he told me how to write a paper, and that was one of the most useful tips. He said to me, when you're ready to write a paper, you know about the topic, okay? So you know what's in the literature. You do not read a single paper just before writing. You sit in your computer and you start writing the introduction and you start writing the discussion. Do not look at anything. If you look at something just in the minutes or the hour before you're writing, you're going to do copy and paste, invariably. If you write the story as you would write it, then the flow is better, the structure is better, the image is better, and you're speaking it in your own words. And then you look at the paper and you put in the reference and you correct whatever was wrong in what you've written. And so that's a very useful tip that I give to everybody. And to this day, I always write that way, especially now I have a bit of a handy people who can work for me and then put the reference in for me under my direction. Okay, so here I am. I've done a bit of research under Tyrone David and Mike de Leval, and I was in Belgium, and I had a decent already beginning of academic career. I arrived in Melbourne, and then I wanted to sort an issue, a problem. I was dying to know what to do with pulmonary atresia vis the MAPCA, because that looked like a complex condition. And Mike de Leval was at the time, coming in Belgium from time to time to do some complex cases or some private cases. And I had seen him doing unifocalization, and Jesus Christ, that was one of the most superb surgeons I knew. And the guy was bitching, struggling, pestering during that operation. And so when you see a surgeon struggling in operation, you have to ask yourself, is that a good operation? Is that something we should do? And so in '98, I was in Great Ormond Street. I had seen the paper from Roger Mee showing that they had very good results with unifocalization with a mean follow-up of 3.6 years. So I was thinking, Jesus, I'd like to know what happened to these patients. Roger Mee was the guy I consider as the best surgeon in the world. He was quoted to me as being the best surgeon in the world at the time. And so I was thinking, if I knew 15 years later what happened, I would understand what to do with these patients. So one of the first things I did when I arrived in Melbourne, I said, okay, I want to follow up these patients. So by the time there has 82 patients, and I had a mean follow-up time of 14 years. So I could look at it, and the survival was, it was still pretty dramatic, but better than what had been shown into the natural the natural evolution of the disease. And so what I did is I look at all the primary results myself, and I say there are situations where the guy who has a look at the primary data has the biggest advantage, and I still encourage the researchers to go look at the primary data. Still to this day, when I see my students or my PhD students, my researcher, and they've looked at, 15, 20, 30 files. I said, okay, what do you think? What stage are we at? What is the answer? Because you get a feel by looking at the primary data. So I look at this angio, and by 15, 30 cases, I knew what was happening. And so I tried to find out what way to express it. And I wasn't happy with this unifocalization. Unifocalization, you can actually, these MAPCA, not always, but sometimes they have such a characteristic shape that you can follow them on with time. And so I had serial angio of this patient. And so I could see before, 2 months, 6 months, 4 years later, follow them up. And I could see what happened to these collaterals. So half of the transplanted MAPCA identified a thrombosed. And then a third of those, a third of those who remained patent had a stenosis of more than 50%. And then when you measure the size of this collateral before and after with a time difference of 3 years, there was absolutely no growth in these collaterals. While if you grow native PA, you can have a growth of the native PA. So I did this shocking title and a very epic debate at the time with Frank Hanley, showing that this unifocalization did not work, and we embarked on a strategy of rehabilitation of the central pulmonary arteries by multiple operation. And the debate is still there to this day, and we've published our policy at the time, and still to this day they ask me to have debate and opposing views with the team of Stanford, while actually over the course of the debate, what's interesting to see is that he moved into my direction, and the thing I'll quickly show it to you, I moved in this direction as well. So I do unifocalization when the rehabilitation is not enough. But what we all agree is that this segment of collaterals between the aorta and the lungs is no good. We know now that is not growing. And as what he started to say after a few years of opposing debate is that, yeah, if you want to have a success with unifocalization, you have to get this PA very far in the lungs. So I think that's an example of what a debate brought in terms of identify the best way of treating this patient. Another thing that I'd like to mark is that, and it's close to my heart, I get excited about that, but how the people are saying that if you have a segment of lungs that is fed by collaterals, if you don't do anything in the first year of life, this segment of lung will become hypertensive. And at the beginning, I accepted that idea. I thought, yeah, it makes sense. You have systemic pressure, it's going to become hypertensive. And then I look at the file of all the patients who died in Melbourne. And Jesus, a lot of people died. And all the autopsy, and they had autopsies. Not a single comment about pulmonary hypertensive lungs. I mean, it's something you can see if you have hypertensive lungs, if you look. I look at the literature, I could find no cases description of hypertensive segments of lung. And so I found out that the only mention of that theory that MAPCA will lead to hypertensive lung comes from a paper from Jane Somerville in 1972. And in that paper, the case 13 had pulmonary hypertensive changes in one of the segments. So that's case 13 of this 1972 publication that led to this dogma. And so we understand that now that if you have patients where don't have central pulmonary arteries like this one, you have one massive collateral going to basically both lungs. There's no doubt you leave that patient with that collateral, he's going to have pulmonary hypertension. I don't dispute that. This patient who's got 7 and 8 collaterals going to minimally, minimal structure there. No way. I don't believe that this can lead to pulmonary hypertension. Not until somebody proves me. And so there's and with all respect, there's nothing yet that shows that it's not good. So following that experience, I would say that, you have to follow the suffering. I mean, if you're struggling in operation, if you see the patient suffering, there's something that can be done. That's the source of your inspiration to do clinical research. I would say that controversy is good, and I don't have to say that to Gil. It's pretty good at it too. I can see that both clinically and at the research point of view. I think we progress the field by discussing back and forth on an idea. And please never believe what the older guy tells you. Do not believe in dogma. You have to make your own ideas about things. So unless you have the conviction that is right, it is a dogma. Any comment on that, Gil?
Nope, just someone has to stir the pot. That's it. But that's what gets us better. No question.
And about the suffering, I'd like to tell you a story. Coarctation of the aorta, very common lesions. The problem with coarctation of the aorta is sometimes, and quite often, you have a hypoplastic arch, and the people say it's 40 to 80%. Wide variation because the definition are poor. Before I went to Great Ormond Street, so I was not even trained in pediatric cardiac surgery. I dumped a little bit all the coarctation of the aorta repair. I was given the shunt because my attending surgeon was going away, and he was suddenly saying to me, "Oh, you know, Yves can do all these operations." So I was left on my own to struggle with this stuff. One day I operated a baby with a kind of arch like that. I put my clamp here. I didn't see what the anesthetist had done, and I'm assisted by a guy who has never seen a coarctation in his life. And I say to him, you know, when I put the clamp on and I do the anastomosis, you keep the clamps together tightly. Then the anesthetist goes, you know, for coffee, as they do sometimes, and leave the junior anesthetist who has never seen a coarctation repair in his life as well there. And then I'm in the middle of my anastomosis and my suturing. And then the anesthetist tells me, "Oh, there's no pressure, there's no pressure, there's no pressure." And despite the fact that I say to my assistant, you know, don't, you know, maintain this, he's moving the clamps to get pressure again, and everything falls apart. I found out after the operation that actually he couldn't put an outline on the right side, so he had an outline in the groin or in the left side, and so the pressure was given by a cuff, and the connection of the cuff was taken off. So the pressure was absolutely perfectly all right. In the meantime, I had a completely ripped off aorta. I ended up doing the repair by clamping the entire, you know, ascending aorta intermittently. Then I had to reoperate immediately the kid, put a graft into position between the two. And ultimately the patient died 2 months later because when I reoperated for a bad chylothorax. And a father was so upset he tried to beat me, and when I let him know about the outcome. That case traumatized me completely, and still to this day, I hate to do coarctation repair on the side because I don't feel that I have the control. That was enough to stimulate me to do research on arches, and I've made a mass of paper on arches, and I think the contribution of that work was to say that when you have a hypoplastic transverse arch, and I got the argument for that, you should do an operation from the front, the same type of operation that initially was described for interrupted aortic arch. And so you see how the primary movements for me to go to that research was just, I suffered so much for them from that case, and I needed to get, you know, that, you know, the expiation somehow of that case led me to drive this research for, you know, I had more than 25 papers on that, and I think it instantly received to make it better. Okay, another topic. I was talking this morning about pulmonary atresia intact septum, and so in pulmonary atresia intact septum, I knew, you know, I was asked, I think it was the World Congress in Cairns, to give a talk about that. And I said, Jesus, I said yes at the time. I didn't have that many invitations that I would say no to, you know, invitation to a World Congress. And I knew nothing about pulmonary atresia intact septum. I mean, nothing more than everybody. So I thought, okay, I had a few months. I put somebody on topic and we review our experience. And so we looked at the different type of size of ventricle and the outcomes. And we look at the long-term outcome, not only, you know, the 3 years outcome, but we look at the 20 years outcome. And so we found out that, yes, you could, you know, in a strategy as we had at the time of aggressive strategy of getting biventricle circulation out of this pulmonary atresia intact septum kids, actually in our experience with, you know, best hands, we could not have a single patient being on a long term, and I speak, you know, more than 15 years, alive with 2 ventricles if the tricuspid valve Z-score was less than -2. So I don't say that that's what everybody should do. There may be people who have very good results with 2 ventricular repair with tricuspid valve Z-score above a threshold of -3, -3.5, I don't know. But what we did in all centers, it was -2, and it was very clear. Then we stuck to -2. And what I mean by that is that you should always look at your result. It's amazing to see what you get from your own results. It doesn't matter what the people around you say or claim they're doing. At the end of the day, there may be things that are working for you that are not working for others, and you should stick to what you can learn from your own experience. By the way, this one is a great inspiration. I use a lot of his quotes. So if I can keep going, so I've done my PhD on fallow and a long-term outcome of a tetralogy of fallow repair. And I did compare 3 procedures. As you know, initially in the 60s, they were operating VSD bioventriculotomy, and fallow, pink fallow, were the same. They're opening, resecting a bit the obstruction, just bioventriculotomy closed directly. Then the majority of the patients had a transannular patch, and then they found out that yes, if you do a transannular patch, the valve ventricle dilates, so the surgeons start doing 1 or 2 incisions, preserve the pulmonary valve annulus. And I had this light bulb moment when I look at the freedom from all adverse event related to RV dilatation, and I found out that if I look at death, transplantation, reoperation for RV dilatation, or even NYHA class 2, 3, and 4, the patients who had a direct closure of the RV were doing better, but the guys who had a transannular or separate incision and patch of the RV and the PA, they had exactly the same outcome. And so that generated the hypothesis that actually, it's better not to cut too much upon pulmonary infundibulum. And it was based on echo data, and everybody criticized me, yeah, but you on echo, you 2 operations with a transannular or just separate patch of the RVOT. You cannot say anything. And Michael Gatsoulis took exactly the same criteria and did an MRI study and proved exactly that actually, yes, I was right just by these subjective echo parameters. And I do that often. I use, a subjective impression. It's okay for me when I look at, the long-term outcome of patients with single ventricle, it's okay for me to take subjective impression of, mild, moderate, or severe impairment of the ventricular function. It's not perfect. It's not a precise number, but it has values. So if you do not have objective data, you should consider subjective data. It's often good enough, and it often fits. And so the conclusion of my thesis was that actually maybe the job that they were doing in Melbourne was what should be done, preserving the pulmonary infundibulum. And I did say that before I even knew I would get the job there. So when I first arrived there, I started as well at the same time to review the long-term follow-up of tetralogy of fallow, more than 600 patients published in JACC. And so we were comparing the benefits of having a smaller incision, which is the big benefits of transatrial repair over the transventricular repair. 75% of transannular incision, and I insist on that, the number of intervention for RV dilatation, so 25% total, but the number of reoperation for RV dilatation, 13%. 13% at 25 years, which I thought was amazing. And then I did something really unusual. I think I had enough patients to compare different surgeons, because I thought that under the umbrella of the same name, transatrial repair, the people would do it differently. If you open not enough, you may have to reoperate patients for obstruction. If you open it a lot, then you may have to operate patients for RV dilatation. And so I did compare, and these are the graphs generated from the baseline to the black line, the reoperation for PA stenosis, from the black line to the red line, a reoperation for RV dilatation, and the red to the green, the reoperation for RV obstruction. And so you see the pattern. I had 5 surgeons who had more than 80% patients who could be followed for more than 10 years. Very controversial. You usually find no papers in the literature comparing the long-term outcome of individual surgeons. Very difficult to find. And so what I demonstrated this is that, well, actually, some surgeons had the same outcomes, and you can see maybe which one, but on the long term, even though it's different, it didn't reach statistical significance. And some of the surgeons had different outcomes. And one guy was exceptional. 10% rate of reoperation altogether at 20 years. I thought that was flabbergasting. I mean, most of the series would show you 30 to 50% rate of reoperation by that time. And yes, there was a difference statistically speaking, but what's interesting as well is that like these two surgeons had exactly the same rate of reoperation at 10 years, but one of the guy had only reoperation for RVOT obstruction and one of the guy almost exclusively for RV dilatation. And so these guys should not open as much and these guys should open a little more. And so, and effectively, if you have reobstruction, well, you don't need to put a valve in. So you can see a lot by looking at individual results. And I think it's a good surrogate for different techniques. Igor Konstantinov was one of my colleagues in Melbourne, and he's a real good friend. We published a mass of paper together. He's very good with, the biomolecular mechanism. He's the only guy who can publish in Nature, Nature about immunologic stuff and being a cardiac surgeon at the same time. And he told me, and actually, I think one of the things he taught me is that it's okay to look at a correlation, but if you don't have a mechanistic explanation about the things that happen and the effect, it is irrelevant. And I always keep that in mind, is that correlation does not matter if you do not have a mechanistic explanation. Okay. The other thing that is absolutely essential in research, and I was talking that to my research coordinator recently, is that sometimes it's difficult to make up your mind, and I'll give you an example. But you should always make sure that you take the solution that does not harm the patient. As a reviewer, as a deputy editor in a large journal, I have to make decision. And at times, the people are coming with numbers that, okay, may justify something. But you know that they pass on a message that's going to harm the patients. You cannot let people harming patients. And sometimes, I don't need paper, but if somebody says something stupid that risks to harm the patients, I would intervene. Without being overly critical, there was a paper a few years ago saying that age at Fontaine does not matter. Why would you say that? I mean, you know it does matter, and it was a poorly designed study on which they're basing themselves. So you have to step out and open the debate and speak out. Especially a person in my position, I have access to so many patients somehow. The people are trusting me in getting this operation. I have the privilege to work in a big institution. So I feel like I have a responsibility to spread the truth if there's something that is important for the patient. So as a young surgeon in Belgium, I was tasked by my boss to look at this valve. And he said to me, we have 2 or 3 patients with early calcific stenosis. I mean, seriously, you have to look at it. And I said, okay, I can look at the results, but I'm going to publish it if it comes out. And effectively, I got the results, small series, it was 200-300 patients. And I sent the paper to a bioprosthetic meeting, which was happening at the time once every 4 years, I think. I didn't follow that, but massive meeting on bioprosthesis, only talking about bioprosthesis. And it was the main session, and my paper was a negative paper and was accepted in the main session with 300 patients, and all the other papers was 2,500, 3,500, 4,000 patients, but it was the only negative paper. And there was a time before the meeting where I had to make up my mind. The strategy of this company, unfortunately, was that they had put that valve on the market, but did not publish a hell of a lot. So there was barely 2 or 3 papers, and they were all focused on marketing, not on results. And so when I came with a negative paper, there was nothing to counterbalance it. And so I looked at the results, and there were 5, 6 early calcific stenosis. In my mind, that may have happened to other valves as well. But in the papers, there was no mention of that. So I cannot prove that there's early calcific stenosis in other valves. There was one other paper which has exactly the same results than mine. And they were saying, oh, this valve is fantastic. And so with the same results, I had to decide. I could have said, okay, this valve is okay. But I thought it was not acceptable. It was not acceptable to have these 4, 5, 7, I don't know anymore, early calcific stenosis in this patient. You don't put a valve and take it out after 3 months. And by the way, the company refused to, they couldn't give me the valve that we sent them. And I asked for a picture. At the time, we still had slides. So I couldn't have an image from the company. And the talks were coming and I didn't have a slide. So a colleague of mine opened his drawers and he had this horrible calcific valve in his drawer for the last 2 years in his office. And that looked really horrible. And that was the first slide of my talk, which was catastrophic. So I learned about, the truth, and I learned about the power of images. And I'll give you another example of the power of images. I talked about, MAPCA. I worked with this guy who was a fellow at the time who did his PhD on bronchial arteries in lung transplantation. And so he was basically a world expert of the anatomy of bronchial artery. And he demonstrated likely that this MAPCA coming from bronchial arteries. And what I found surprising is I got this drawing explaining how you have this little collateral between the native bronchial artery and the pulmonary artery, and they can develop if you have atretic pulmonary arteries. And what I found is that these drawings is so convincing that even when the people see a drawing, they forget about the statistic and the science behind it. When you look at it, you say, okay, if you see it, you think, okay, that's the way it must happen. So this is a hypothesis, but in the way it was quoted later on, I could find out that the hypothesis becomes reality in the mind of people. A few tips to finish again. There's power and quantity. I think that, the time today in research helps you if you have a mass of paper. So if you have, 100 medium-sized paper rather than 4 big ones, you're quite privileged. We're talking about books and role model. Roald Amundsen is one of my role models, and I have that picture in my office. And his book is one of the most is my most important book, I think. And I was always fascinated by Antarctica and the infinity and the absoluteness of this area of the world. But what I liked is this expedition. In 1912, Roald Amundsen tried to get to the South Pole, but cannot he's trying to get to the Northwest Passage, getting blocked in the ice and migrate all around the North Pole to show that there is no land all around the North Pole. But that's a 3 years expedition. I can barely find money for 1 year. Then in 1908 to 10, the North Pole is found, and it makes an enormous noise. And so Shackleton in 1908 also had almost managed to get to the South Pole. He was arriving 50 miles out of the South Pole, but at the time he had been just trailing the food behind him with just skis. Amundsen is born in Norway, so he thinks that if the guy had been with dogs, well, he would have reached there. And he thinks, he's looking at all the charts and the at all the records of people traveling there, and he sees that actually here it's possible probably to land. The highest shelf here is about 100 meters high, but here there's a little bay where he could go, and if he goes there, it's even shorter. So he doesn't have the money to go to the North Pole. He said, okay, I'm going to go to the South Pole. I couldn't care less about going to the South Pole, but that's going to be a good advertising. And then I get all the money I want. And so he goes in the South Pole. And at the same time that Scott from England goes into the South Pole, Scott goes and he tells about his tales, and they're drinking sherry and talk. Here, they're working night and day. They pass the whole winter, and they work on their sledge. They take 50 kilos of each sled just to go faster, and they follow a very strict discipline. While Scott has made this tractor. He goes with horses in the South Pole, and they end up, pushing everything by hands, while Amundsen is going with dogs. And Amundsen arrives, and Scott dies in the expedition. And so I love that stuff because it's basic thinking, and that's what drives you in research. You have to make 1 + 1 = 2. You have a sense of reality. No fantasies. You have to have expert knowledge. You know as an expert what's right and what's wrong. You make your background research, preparation, discipline, hardworking. You take risks. They go in and you read the books. They go through crevices. They were unbelievable. And they do that as if it was nothing. And then it's a whole question of telling stories, attract the people attention. That's how you get things done. My other role model is, I don't say that I especially liked him, but Jesus, the guy impressed me. He gave a talk about perseverance that I will never, ever forget. The guy is so dismissive of all the people abandoning after a few attempts. That's quite amazing. And then the most famous quote that I give to my colleagues is, success consists of going from failure to failure without loss of enthusiasm. And if you do research, you have to remind yourself that. When you get your paper knocked off, when you try, 3 different times to get money for a grant, keep going. Thank you very much. Sorry, I hope I haven't taken too much, Gil.
No, Yves, that was perfect. I think that's really a great start. There's a couple things that came through, and I always appreciate some good quotes from Winston Churchill. One of my favorites is, "You'll never get to your destination if you throw rocks at every dog that barks." And so, sometimes I feel Rounds works that way. It's fascinating. I had a question. I wanted to follow up on something that Dr. Deshpande said in our chat box. As a surgeon, as a clinician, and as a researcher, we have to balance confidence and dogma and consistency and an open mind. And I think what Sri said is the idea that you mentioned about Dr. Norwood, which is perseverance, is how do we remain strongly convicted to what we think is the right thing to do. And in the context of all that you spoke about, it's quite clear that you have strong opinions and correct opinions about the things that you have researched. How do you, and I know I have trouble with this, how do you objectively read or review a paper that contradicts your previously held beliefs? Do you feel you have an open enough mind for that? I struggle with that. I bring that up. The team, Main Waring and Frank Henley, review every single paper I write on pulmonary FSD MAPCA, and I'm pretty sure I'll review and read every single one of their papers. They always send them to me, of course, because I'm the, perceived as the opponent. I think that as a reviewer, because if you're an editor, it's easy because you get the advice of other people. As a reviewer, you have to step back and look at the evidence. And somehow I can disagree on something, but you can be relatively objective. They have the data, they have the evidence, and they can make a claim. And so as an editor, it's easier because then you can, you make sure that you have somebody that can comment, that has got an opinion that is opposed to them. Or as an editor, you confess, sometimes you direct it, you send it to reviewers where, more that they're more likely to, reject or accept or something. But the main driving thing is that I can disagree with some statements that Stanford doing, for example, but they're excellent. They're doing a good job. They've shown it, they publish it. It's fine. People can do something differently as long as they show what they're doing and the results are decent, at least decent. But they have to provide me numbers. So I accept and agree with things. But if they're harming the patients, that's a no-go. There's examples. I read the paper and I say, if the people will read that, they're going to start harming the patient, and then that's a no-go. I'll give you an example.
You know that. Sorry.
example from my own personal experience, because I wonder how you do with this, and I'll pose it as a question. So as you know, I did a lot of work and have done a lot of work with milrinone in a randomized trial. And we may talk about that a little later. So I found that when I read a recent paper that John Costello wrote on a randomized trial of milrinone placebo and nasiratide showing no effect after a Fontan operation, I have to be honest, my first response was to dismiss the paper or find flaws in the methodology, because I had a real investment in that particular topic. And there's many other, it's that self-recognition for me that's very important when I read other people's work that contradicts my previously held belief. So for example, if we were to see a manuscript that was different results than that beautiful example you showed about what's the optimal way of leaving enough obstruction and not enough dilatation, or how exactly to do a tetralogy repair. How do you read that objectively if the results are different than what you feel very passionately about?
I've been in that situation. Marshall Jacobs, they published something about, lateral tunnel versus extracardiac. And on the STS data, the morbidity after extracardiac was higher than after lateral tunnel. And I wrote a fiery letter, said, how is that possible? You can, blah, blah, extracardiac is fantastic. Then, Boston recently showed something. And then I have 15 years later, I have a lot more experience. And I realized, I get it. Extracardiac conduit, you can have a lot more technical issues than usually. And so I've wrote 2 papers now on the problem that you can get with extracardiac conduit. And I'm changing my mind. So I'm a more mature person nowadays than I was 10 or 15 years ago, I would hope. And so I got now that as extraordinary as it looks, I know that sometimes I'm wrong and I'm going to change my mind. So I try to keep.
The last time was 2006, I think.
About that, yeah.
No, I think, especially for the international people who are attending, the balance of dogma, we want to be doing the right thing. Nobody wants to not do the right thing, so we can feel very strong in our convictions. And it's very challenging, research-wise and clinically, to keep an open mind against previously held beliefs. And that's the point I really want to make.
But keep in mind that the public should understand that the real truth is coming if you have a lot of concordant papers. And if you have a mass of paper, you're going to have some negative. If you have no negative paper on any topic, it's likely that there hasn't been enough work done on the topic. So it's okay to have some negative paper. It's the mass of, the truth is the mass of all is given by the mass of all papers. So controversy is all right. It means the people are thinking and working on it, which is what you want. If the people are working on it, we're going to progress in the field. Huh?
Yeah, I completely agree. Grace, do you want to take some of the questions? I also want to start out, it looks like we're getting a number of people that are joining now at 11 o'clock, and I want to apologize to them. We sent out 2 different times in our notifications. Dr. Dudekem just gave from 10 to 11 Eastern US time, just gave a fantastic review of clinical research, how he got to the position that he's in, tips from his mentors. We're going to continue to do some things for the next 45 minutes or so. But if you want, for people that are joining late or anyone that wants to share with their colleagues, this entire webinar will be available on our YouTube channel. And we still will be doing, I'll be talking again for another half an hour, 40 minutes at this point after questions for Eve, and we'll go from there. So I'll turn this over to Grace and then I'll go the second part.
Thank you, Gil. And it was really amazing. We couldn't stop paying attention to what you were saying. It was very, very good. Thank you very much for that. We have a couple of questions on Q&A chat box and some on the chat box as well. Guys, please type on the Q&A so we can have a track of what we are asking or not. But there's one on the chat box that something that's very interesting that I really want to know the answer and your thoughts about it. You and Gil and Sasha for sure. Madonna Lee is asking, do you have advice when you are showing your home institution their outcomes data internally and it contradicts what they believe or what they think?
Keep trying. It's Winston Churchill stuff, but you keep hammering the nail. 1, twice, 3 times, 4 times. Repetition helps to convince people. Repetition, and then you have to. The other thing that may work as well is bribery. If you get a good paper and you can publish it in a big journal with their names on it, they're gonna get kind of entitled, you know, they're gonna be bound to an idea that is not theirs, but they're gonna have to approve it because it's on paper with their names.
I'll add to that. We have to, you know, I think human psychology will always say that we tend to remember our last difficult case, and we'll forget the Glenn who went home in 3 days. We'll remember the Glenn that stayed with chylothorax. And as Eve has mentioned, and I couldn't agree more, it's the data, it's the data, it's the data. It's not the last case that we had. It's the data, cumulative.
And then there's nothing like a lifetime of hard work. You know, it's funny, but in my career, I was always the funny guy. I was never the guy looking like a professor because, you know, I was, you know, party guy and making jokes and so on. Then nobody took me seriously. It's only after a few hundred papers that people, then I had to take care, because when I was making jokes, then the people tend to believe me. So, you know, if time will help you, you know, just waiting, your time, you know, you can say to the person that your time will come. Keep persisting.
Yeah, Eve's been at Children's for 6 months, and some of us are beginning to take him seriously now. So,
very good. There's another question and saying, for the young investigators, it always feels like the question you come up is important in first instance, and then the enthusiasm dies down as the feasibility question arises. When, even though we know that there are questions to be answered, how to get over this block?
So the thing is that, so for me, yeah, the tricks that I do is that, and the reason why I'm successful is that I always like to have a lot of reward for little investment. Okay, I give you an example. We used to put a dermabond on leaky BT shunt. That's a stupid stuff, but I thought, shit, it's only for external use, and I'll use it internally. If somebody gets me, I'm gonna, you know, I'll go on trial, I'll be condemned. So I think I'll publish it. And the only goal was, you know, publishing it for making sure that, you know, if it's peer reviewed, it's accepted practice. So we took a picture. I had the one of English trainee who was there, took him about an hour to write the stuff. And within a total of 1.5 hours of work of both, we got 1 paper. That's a good ratio of investment and reward. And so you start with small stuff. So in the terms of feasibility, don't try the grand scheme. So for the Fontan registry, I started to do okay, I'm ashamed of that, but Fontan, you know, I did a lot of work on Fontan. I heard, it's a terrible story. I heard that a fellow, 2 years, in 98, and arrived in 2003 in Melbourne, in 98, had did a review of all the Fontans, but it was never published. So I go to Dr. Wilkins and I say, can I get this Excel database? And so I got all the follow-up and everything done from the whole experience up to 98. I had just an extra 5 years left. So I put a medical student on it who updated the follow-up. And now I had 300 patients with a complete follow-up. By the time I published, I forgot that I got this Excel file, and the author of that person, I'm sorry, I don't know who it is, but it has never been on the paper. So I'm sorry. But so I got something already and I built on it. And then I had 300 patients. So from going from there to the Fontan Registry of Australia and New Zealand was just a step back and so a step up. So I first got an audit of getting the follow-up that was in the database. And then I get, so you just go gradually. Don't set up on the grand scheme goal. And you always look at what is realistically possible in your town. And if you're a clinician, you're busy. So you go for the low game and build up on it.
Yeah, totally agree. That's it. And I think Gil has more comments about that on his talk in a minute. And there's one other question that is very interesting. Any advice on how you were so successful in grant funding?
It's a question of a story and finding the right moment. And so you somehow with grants, you have to be the right person at the right time. And so my funding for a registry was successful because that was the right time. And then in a tighter environment later on, it got much more difficult. Right now, the NIH would favor grants which comprise the trial. So you go for trial components. You have to be clever, but at the end of the day, it's a grant funding. Then it's a storytelling. You have to know. You have to know what they want to hear, and the way they want to see it. So you have to be clever. I had to learn how to write the story. So some grant application, you need to look like a professor, and some grant scheme are read by a physiotherapist and nurse, and then you have to adapt your language. So the form is extremely important. The way your grant looks like is very important. It's not only based on just the hard science that is behind it, I'm afraid.
Oh, very good advice on that.
I want to add something to that, Eve. I think that's brilliant. And certainly for people starting their career in research, just like the type of paper to write, start small, ask a lot of questions, ask for a lot of help. As Dr. Deshpande said in the box, I think that too often the great ideas by young investigators that want to start with a randomized clinical trial that's going to cost $4 million, it's not feasible. That's not where to start. However, if you start to work with someone who's on an NIH R01 funded or randomized trial early in your career, by later in your career, that will come.
I think we can answer one more question and then move forward to your talk, Gil. What do you think?
That's perfect, sure.
Okay, so how to deal, this is a very interesting question, how to deal with the problem that is common in congenital heart research, the small number of patients and very large number of variables for each patient, how to deal with that?
Sorry, a large number of variables for a small number of patients, is it? Sorry?
Yes, that's it. So he's asking how to deal with this common problem, that we have a small number of patients and in each patient there's a lot of variables.
So if it depends on what problems you're looking at, and there's virtue on looking at a small number of patients. I'm currently asking one of my students to do a paper on the less than 1.5 kilo at birth who have cardiac surgery. It's 15 patients. If I look closely at the data and I read the stories, I will learn something. You know that the whole of pediatric heart surgery has been built on a magic number that is very small. My own number is 3. If I do an operation 3 times and it fails 3 times, I'm going to do something else. And that's the way that people have, and so the numbers may be different. It's just probably about 35 for Norwood, but you know, the number varies from one individual to the other. But you need a very small number of patients, and you don't need any statistics to understand something. So you know, with a description of a small number of patients, a good description, a good interpretation of what's happening can help you without statistics. If you want statistics, you need to have larger number. And if you want statistics, you forget about having multiple data. The larger the number of patients, the less number of variables you study. I'm building up an international frontline registry now. The number of variables we'll be collecting will be ridiculously small. You know, death, reoperation, a stroke, functional status, PLE, plastic bronchitis, transplantation. That's it. You know, that's all you can do. If you get more data, you're not going to be successful. Not on several thousand patients.
It was interesting what you said about 3. I've heard someone say that if you see it once, you've seen it in a case. And then if you've seen it twice, you can say in my experience. But if you see it 3 times, you can go case after case after case as shown. And then you know that you can sort of move forward with you have pilot data.
Gil, I think, thank you, Yves. It was really, really important to all of us to learn from you. Gil, I have one question before we start your talk. What is this behind you? Is that a doll? Is that a poster?
Where?
This
It
kid.
looks like a dead child.
Yes, it is.
No, it's my grandson. It's my kids, because we couldn't see him in the pandemic. They sent his name's this is Flat Asher.
This is so sweet.
He keeps me honest. What can I tell you?
This is really, really sweet. Thank you for that, Gil. Okay, thank you, Yves. And please, Guy, continue to type your questions on the Q&A chat box. We are going to have more discussion in the end of the session.
Okay, so I have to see if I can open this. Let's see. Share screen. There. Share. We should be good to go now. Is that correct?
Yeah, we are good to go.
Okay, very good. As I said in the middle of this, and again, to people who joined late, we started 1 hour ago, an error on my part, so we had 2 different times to start, but both of these talks will be available on our YouTube channel beginning this evening. Eve and I did not plan on saying the same things. We're going to have, I would say, 95% agreement with a couple of things different along the way as we talk about our experience with clinical research, both from the beginning of our career to where we are now. Before we start, this was mentioned before, the Congenital Heart Academy is partnering with the Fetal Heart Society for the first time on April 8th. This will be very late for Europe, but doable in Asia Pacific, Australia area. This is going to be very interesting, not only presentation, but panel discussion on the physiology and definition, anatomic definition of transposition in the fetus. Down at the bottom of this is tinyurl.com FHS webinar, which is Fetal Heart Society, and we're very excited about this partnership with the Fetal Heart Society. Here. Eve started out with his research profile. I didn't know these things existed, but you can look up sort of what's happened in your research career on Google Scholar. And it was interesting. This was certainly, as Eve said, this was certainly a direction I never thought that I would go in. I was pretty sure I was going to be an outpatient pediatrician and then an outpatient cardiologist. But you know, you get exposed to people early in your career and they take you along the way. And I said, I think for Eve and for myself, the most important thing is you see things happen to your patients. And then you want to improve on that. You develop a question and you have to ask the right question. If you do research on exercise physiology and you work in intensive care, there will not be enough harmony. It's important for you to do research where you do the majority, in my opinion, the majority of your clinical care. If I can just call your attention, left side of the screen, the first paper that I wrote was given to me as, you know, you have to write a paper as a fellow. And so I wrote a paper on transposition. And then the Boston Circulatory Arrest Study was being designed by, I'm on the top of the slide now, it was being designed by Richard Jonas and Jane Newberger. And they needed a sort of clinician to get a lot of the consents and to write the documentation and run the cardiac outputs and whatnot. And so I was able to learn about an NIH-funded randomized trial by having written my first really small paper on 50 patients who had an arterial switch operation, and that was back in the 80s and early 90s, which started my work and my interest in CNS research. Now, that would never have been sustained if I was not an outpatient cardiologist. And I was bringing that research into my patient population where I could speak about endocarditis and exercise restrictions, but what the parents were most concerned about was school and how the kids were doing in there, which led me into the research for long-term neurodevelopment and as well as cardiac surgical and other outcome studies, really starting to get at a handle of how can we improve the quality of life for these kids. But I was also working in intensive care. And as part of the circulatory arrest study, we were able to define the definition of low cardiac output syndrome, the fall in cardiac output the first night, which led to an industry-funded study on milrinone, which is the Primacorp study. And I simultaneously was working on what was going on in the intensive care unit, improvements in CICU care, whatever. And so I've now in the last part of my career, which I never would have guessed, I've been able to mold or merge those two things with what can we do in cardiac intensive care that will improve quality of life and neurodevelopmental outcome. If you had asked me in '85, there's no way I would have guessed that that's where we would be heading. And as Eve talked about, now I get to the real privilege of seeing the younger generation take this ball and running with it. Sarah Schlatter, Melissa Jones, Jessica Carpenter, Cheryl Caparola, and a huge group of people are working on this in our unit so that we can start to think about what happens in that 2 or 3 or 4 weeks of care that we do that sets kids up for life, and how can we do a better job of this. How do we describe what these studies were? Well, this is what I was told by Dr. Natus. Dr. Alex Natus is in the blue shirt there, and on the ground is Don Filer, and they were very key instrumental developers of pediatric cardiology's clinical field. Dr. Filer, who's sitting down, was the first to set up a computerized database in the early days of computers in 1980. So the Boston data goes back to 1980, which is now 40 years old. What I said first is not exactly correct. What Dr. Natus told me is the first thing you have to do is look something up. Look something up. And then the second thing you have to do is measure something. And then the third thing you have to do is measure something, change something, and measure it again. And he said you had to do it in that order. And what I didn't know at the time was what he was describing was a retrospective chart review, followed by a cross-sectional study, measuring some, I'll give an example of that, followed by a clinical trial of some sort. This was a very helpful thing for me. So look something up, measure something, change something, and measure it again. And someone asked in the chat box, the feasibility can sometimes be a problem. And usually that's from people trying to start their clinical research in the third category before they've done 1 and 2. And the key part about the first part that I didn't know, but I certainly tell the younger trainees now, is you have to learn how to write manuscripts, how to read instructions to authors, how to get statisticians involved at the beginning. And if you start with something big, it's very likely to not be successful. I was really lucky to work with these 4 wonderful mentors and still friends in Boston. Dr. Jane Newberger and Richard Jonas brought me on as a first-year attending to the Boston Circulatory Arrest Study. Dr. Peter Lang was my clinical mentor early on, and Dr. David Wessel, a research mentor, particularly with industry-funded trials, as you can see here. I still stay in touch with all of these people. I have the privilege of still working with Dr. Wessel. Dr. Jonas just retired, and Eve has taken over as chief. Jane is a consultant for me on the phone almost monthly. And Peter, as well as Bill Norwood and John Murphy, really started to work on understanding how the blood went around and what were the challenges of neonatal operations. And really were the key people that I developed in my career. And to get to that research profile is not only the people who taught you, but we have a responsibility to pay it forward to our junior attendings, our fellows, our nurses, our NPs, our researchers. It is our job at my generation, Eve's generation, and then we learn from them. And that's the circle of this entire process, because that's how all of these things get written and move forward. So I'm going to share a few tips that Jane gave me, which is, I think you all know about these types of study designs. Cohort studies can be the ones where you look something up or you measure something. Case control studies, evaluations of new diagnostic tests, and experiments. And one of the things that this slide was there to remind me, again, is to involve your statistician from the beginning. They should be involved in the design of your case report forms and data collection forms, so you don't have too much data, as Eve was just talking about, and that you're collecting categorical data that should be categorical and continuous data that should be measured as continuous. You need to get that evaluation done before you submit to the IRB. A mistake of many junior investigators is they collect a lot of data, then give the data to a statistician and say, okay, make something significant. That's not the way to do clinical research. Your statistician should be involved in the design of your trial and to take that question that you have, that key research question, and fine tune it into something that could be answered with available data. You will want to choose a project that will lay a foundation for the future, for your future work. In my experience, that was, I wrote a paper on the arterial switch. I learned and read hundreds of papers on transposition, and that allowed me to take the next step both in the ICU and with clinical research. Ask why a project hasn't been done before. If you're starting something new, is it too time consuming? Is it not feasible? Will people not give consent? Will the IRB decline it? I love this one. Is the question important? Would you read the paper if someone else wrote it? So before you start the project, ask some of your colleagues, your fellows, your nurses at the bedside, the outpatient people, your attendings, would they read this paper? And what's your role and credit secure? And I can't emphasize this enough. It's important at the beginning of this, and you've mentioned this before, outcome studies are a team effort. If you're going to look, I'm an intensivist. If I'm going to include echo reports, I must include an echocardiographer, not politically, but an echocardiographer is going to look at the question from their lens and figure out the best way to collect the data. Should we use the reports? Do we need an independent reviewer? Do we have a second reviewer to look at 10%, to look at inter-observer variability? If you're going to include cath results, a catheterizer should be on the study and on the manuscript. And then once you know who your stakeholders are, everyone agrees on the work distribution, and very importantly, everyone agrees on the order of authorship before any work gets done. You do not want to have people expecting one thing and then a second thing happens. As I said before, join an established, well-funded project that's led by a mentor and learn from them. And I learned from Jane Newberger, David Bellinger, Richard Jonas, Dr. Castaneda on how to jump onto an established study and just do what you're told. And eventually ideas will come to you as you move forward with that. Pursue an independent content area. Start to focus your career. If I look at a CV of someone who's written about Epstein's anomaly and inflammation parameters after bypass, line complications and tetralogy, that's an unfocused person. Figure out what you want to add to the field and what question you have and become focused in your direction, and find a mentor who can help you with that. Gather new high quality data, which is a prospective evaluation or a cross-sectional study, or as in Eve's case and case in Boston, use an existing database and decide how you want to move that database forward. And then think about if the study has been done or the data has been done before, and I'll talk to this later as we talk about paper writing, the reanalysis of published data, decision analysis, cost effectiveness analysis, a meta-analysis. It may not just be where, as Eve was talking about, where to put the patch. Is it transannular? Is it transatrial? How do we do this? What's the cost difference? What's the length of stay difference? There may be some other things that are important separately from the primary outcome. I can't emphasize this enough, and certainly to senior people in the field, you must keep a mentor. Not only find a mentor, but keep a mentor. We all need reality checks. And as we get older in our field, it's less and less likely that we have someone to bounce ideas off of. And when you think outside our own field, in American football, Tom Brady has a coach, Pablo Casals has a teacher, but we become the chief of the unit or the chief of surgery. Who is helping us? We all need that. Consider co-mentors. If you're doing a discipline, you may want somebody from the CDC. I know there's some people moving to the CDC on the call. which is fantastic. Get people outside of that arena to help you rethink with a different lens. Good mentors can be hard to find because they not only need the knowledge base and skills that you need, but they need to be a little tough on you, ask thought-provoking questions, teach you to be detailed, give you constructive feedback. And what's not on this slide is available. So it's great if someone says they want to be your mentor, but if they don't have the time, that doesn't help you. From a mentor's perspective, you can't work harder than your trainee. So if you're the one doing most of the pushing, that trainee needs help more than just research. So for fellows, mentorship team, for faculty, it's the record of productivity. That's how you get grants, which was a question in the last hour. If you start with a small one, that looks good as you're applying for your next one. Now you have 2 applying for your 3rd. You want to have newer original ideas. You want to start with a reviewer, as many reviewer-like people around you as you can. So if I'll take a couple examples, we have some of the people from Children's National on this call. You're going to want to float that idea not only by your mentor, but 5 or 6 other attendings. See what they want to do, and then time management. Whatever time you think you're going to need, double it, because it never works as short as you think you're going to need. I can't emphasize this enough: is exquisite detail to your methods. And as I'll show you later on, it's the methods that determine the success of your project, not the idea. The idea, along with consultation from statisticians and a lot of smart people, is what's going to determine your methods section, and then you follow those methods. They precisely describe the logistics of your study, who is in, who is out, how the case report forms go. The methods are the most important part of how you start your project. There's common reasons for failure: either failure to complete the study, failure to present the study, failure to get the study published. The first is lack of clarity and focus. Your aim must be as specific as possible, and your primary aim cannot have the word "and" in it. If the primary aim is mortality and length of stay, you don't have a primary aim. So you want to have a primary aim that is very specific and measurable. The next is lack of acceptable scientific rationale. As Yves said before, you can come up with a result or a p-value, but if there's no biological plausibility of that result, you really have to question the validity of your research. Another thing that is a reason for failure is if you haven't started with an extensive review. And as Yves said before, you need to sit down in front of your computer and read and read and read. And then if you read papers, look at the papers that they cite and read again. You will do yourself a big favor by spending a huge chunk of time in that answer and in that part of your study. Many fellowship programs in the US, I'm not sure about internationally, have fellows do occasional chunks of 1 month of research in a row, maybe 2 here, then you get a bunch in a row. The key in that month or 2 of research is to read, find your topic, and become the local expert on that topic. Another reason for failure is there's no pilot data. You just start off. I can't emphasize this part enough either. In the Boston Circulatory Arrest study, we did 27 patients, randomized 27 patients, before we double-checked that the study was doable from a case report form. We had to throw out the results of 27 patients because we did not do a pilot study on the case report forms. So if you're going to do any type of research, pilot that. For example, if you're doing a retrospective chart review and you're going to include 100 patients, and you find it takes 8 hours to go through one chart, you have to say, okay, where's my 800 hours going to come from? You must pilot how you're going to do this study. We talked about the methods, lack of a critical approach. Don't fall in love with your first answer, just like you don't fall in love with your first diagnosis. And then the lack of value. If you're doing something that is just going to confirm something in the literature, that's fine if there's 1 paper or 2 papers on the topic. If a third center finds the same thing, that's fine. However, if you're writing just to write something that's already been described, it is less likely to get into a journal. And if it does get into a journal, it's less likely to be read. All right, so I'm going to close with just a couple of things, which is taking an idea to you've done the study, how you submit an abstract to a national or international meeting, a couple of presentation tips on the so-called 10-minute talk. I'm going to talk a little bit about when to write the paper, and then what Jane taught me, which I teach everybody that I now work with, is the 7 paragraphs, and you only need 7 paragraphs in a discussion. So there's only one purpose to submit an abstract. It's not to show off your research.
Can I interrupt you, Gil?
Oh, please do, Yves.
About the 7 paragraph and the conclusions is that, you know what I do, and I still do. When there are papers, I decrease the size of the paper and I look at the length of the results. And my basic rule is that your discussion should be shorter than your results. You cannot have half a page of results and brag about 3.5 pages. If you have half a page of results, then you have a half a page of discussion.
That's a very good point. I don't have the mathematical formula, but maybe we can talk about that at the end. I think that's a good observation. Again, many people have the wrong idea about abstracts, and they try to cram their entire research project into 500 words. There's only one purpose of an abstract, and that's to get on the program. Because if you don't get on the program, no one sees your work. So that's why it's key to have a primary endpoint that is important. The secondary endpoints will fulfill your board requirements or make your mentor happy or get you a free trip to an exotic city, get rich and famous like Dr. Dudechem, or get out of a rotation you don't like. All of these things, it looks good on your CV, and I'm going to get back to that. But if you don't have a good and important primary endpoint, where you go from that first paper is very different. So those other reasons, well, I have to do a paper, I have to get to the American Heart Association, I get to go to New Orleans or Brussels. That's cool. But the real purpose of your abstract is to get on the program, and never lose sight of the fact if the abstract is not accepted, nothing else matters. So what are the key features of getting it accepted? Do not try to get your entire research project into 500 words. Even if you could, it won't matter anyway. So pick the most important things that are either unique or controversial or impressive, like the Fontaine operation in 1,700 patients, volume matters, or is different than what other people have done. And make your abstract build around that. So again, it may not necessarily be what your ultimate point is. If you don't get on the program, you can't present your ultimate point. So your abstract has to be very focused on getting on the program. I'm not saying that it's anything less than honorable, but the focus of an abstract absolutely can be different than the focus of your 10-minute talk, right? 500 words is one thing. You get a lot of time to expand on those 500 words. So choose those 500 words very carefully. Another thing that I'd recommend is if you're comparing groups, particularly in an abstract, group 1 and group 2 or group A and group B, make a reader go back up to your first sentence over and over again. So name the groups so that the reader, and the only important reader is the abstract reviewer, can remember them by the abbreviation. So I picked one here, hemofiltration versus non-hemofiltration. A challenging or controversial titer, hypoplastic left heart syndrome is not associated with low cardiac output. If I was an abstract reviewer, I'd be, whoa, what are they talking about? That's not true. And you'd want to see that paper presented. And then the KISS principle, keep it short, keep it straightforward, keep it simple. All of that is going to be important. So this is the conventional format for an abstract, and not all of these are created equal. And what you'll see, and this is different than a manuscript, and Dr. Duda can refer to that in just a second, what will get the abstract accepted? The results. That's what people are going to be looking for. Any of those 500 words you waste on background are things you can't present in your results. People will look at the last sentence to see if they want to read the whole abstract, but as an abstract reviewer, if your conclusion is not supported by results, you will not get on the paper. You will not get on the program. Don't try to make more than 2 important points about your data in the conclusion. That's too much in 500 words. Give them the most important point that will, I can't say this enough, get the abstract accepted. Here's a few things that will kill an abstract acceptance. An abstract that's not geared to the appropriate target audience. So if Dr. Duda wrote that wonderful paper on valve calcification and went to the ethics section of the American Academy of Pediatrics, could be the best paper in the world, not going to get accepted. If I see this in an abstract review, the complete data will be available at the presentation. It's not going to get accepted. You have to be able to present that in your abstract. Again, all conclusions have to be purported by the data in the abstract. And I'll get back to that in just a little bit. Distinguish the difference between conclusions, which are supported by the data, and speculation or clinical implications, what the data may mean. One thing that it won't necessarily kill, but will wound your acceptance is a conclusion that's really a speculation. So if so, you need to add things that we speculate or the data suggests that we should. These are things that are going to help your abstract get on the program. Then there's some politics and timing issues. Most abstracts will in fact be published, so all of the authors need to agree on the material. This has happened throughout my career. It's happened 2 months ago. Be respectful of your colleagues that will not have the time on the day the abstract is due to drop their other responsibilities to review your work. So you need to sort of reset when you want to have your abstract done. And the more authors you have, the more time you need to provide for a review prior to submission. I would recommend at least a day per author that's been involved in your study, but at a minimum 1 week before the abstract is due. I can't tell you how frustrating it is when, for example, the American Heart Association abstract is due tomorrow, and I get the abstract at 6 o'clock tonight. I also recommend for people, if you haven't had a chance to review the abstract, to take your name off it. You can still be on the paper, but if you haven't reviewed what's going on in that abstract, it's not to your benefit to include your name. Keep the author number down to those that actually contributed to your work. That's at the abstract time. You can always add more at the time of your manuscript submission. And as I said before, don't use the abstract deadline as your planned submission date. Your senior author could need an appendectomy. You never know. One of our senior authors needed an emergency lap cholecystectomy. Those abstracts couldn't go in. So you've got to give time for that. All right, let's move over to the 10-minute talk. So now you're on the program. So the purpose of the 10-minute talk, and this is again in my opinion, is to get your information out there, the work that you've done, and to practice teaching to a large audience. The conventional format is, as we talked about with abstracts, are background, methods, results, and conclusion. Not all sections are created equal. And what will people remember your presentation? And I couldn't agree with Dr. Duda more on that beautiful slide of bronchioles. It's the results, but in particular, it's going to be one particular part of those results. Those were doubled. That's what I and many call the aha slide, where you look, it is not text. It's a slide that you look at and go, ah, I get it. Just like Eve was showing before about the bronchial arteries going out into the lung fields. So you may need 1 or 2 of these, but people should leave your 10-minute talk knowing what you did, why you did it, and 1 or 2 new things that are new to them. The way I learn is with figures. I'm a visual learner, bar graphs, pie graphs, things like that. Big changes in color between 1 and 2 results. It's interesting, when I talk with Jane Newberger, she remembers things from tables. she'll look at tables and want to see beta coefficients and things like that. We all learn differently, but the majority of us will take home a take-home slide that is visual. You can change the font. It's okay to change the background color once or twice in the presentation. That is at the aha slide. I'll give you a couple of tips. Without knowing what these things are, you know that gray is more than black. And then you can look forward and say, oh, that's absent, and get an idea what that is. Survival is the y-axis. I want to be on the top line. I don't want to be on the bottom line. What goes into that top line? A pie graph doesn't do you any good at this level. Well, now we know, okay, it's probably a drug study, and you could see that this was the percentage of each patient. Well, that's not a very well-distributed study. Or you can look at it this way, say, oh God, patient survival was terrible in placebo. I want to use that high-dose medication. Now, that's when you title the graph this way. But look at the impact a slide will have if it's this way, that says, my new drug significantly improves outcome, rather than results : 3. So it's helpful once or twice a talk to change your title slide rather than methods or results to the statement that people will remember. And if they put that together with a graph, you've done your job. You've answered your primary endpoint. So how do you prepare it? Time management. So slide preparation should begin at least 1 month before the meeting, and you run it through that with your mentor. 2 weeks before the meeting, present it to all your colleagues, practice it, and expect to be destroyed. It feels terrible at the time, especially you want it to be, because you want the questions that you might get at the meeting to be asked by your colleagues. We always have tunnel vision about our project, and you and your mentor may have tunnel vision, but your colleague who's an electrophysiologist or a surgeon, always make your talk better. And they'll give you a broad overview. And if you're reviewing in the audience, I thought the big talk was like this, and then let's go slide by slide and look at the way it's formatted. Got to have thick skin for this, but it will make your research career better. I was told that I needed to talk from my slides from the very beginning. It was exceptionally uncomfortable. I'm glad I learned to do it that way. There's no right or wrong way to do it, but I think that you will be more comfortable as you know the data to talk from your slides. You saw Dr. Dudekam talk today. It wasn't from any prepared script. It was from his 30 years of experience and a great understanding of the topic. And then the last thing I want to talk about is your responsibilities after the 10-minute talk. Obviously, you take a deep breath and you thank people. You thank them at the beginning and the moderator. And then you thank your colleagues or show the picture of the people in your lab. Now, manuscript preparation. The best way to not get a job is to have 13 abstracts that never turned into papers. That tells you that you don't complete projects. It tells me that you don't complete projects. I strongly urge people to write the entire manuscript out before the meeting. You'll know the literature, you'll know your project. If you had done your IRB submission properly, you will already have written your background, methods, most of your discussion, and most of your results where you then plug in the analysis. You'll know it better. And then the people that ask you a question in the audience are pretty likely to be people like those who will review your paper. And so many people will do this and say, oh, I'll get the paper done later, and then they don't become papers. In my view, the completed manuscript should be on the senior author's desk within a week of the meeting. And there are some pretty harsh chiefs out there that won't reimburse you for the trip until the manuscript is submitted. But if you want to have a successful research career following this approach, which was not only pushed to me by Jay Newberger and Dave, but also by Jim Locke, you've got procrastination will kill this. Get that completed manuscript done before the meeting, and then tweak it and send it in. Then finally, a good talk is one that ends on time. A great talk is one that ends early. So to summarize, the purpose of an abstract is to get on the program. The most important slide of that 10-minute talk is that beautiful figure that says what you want to say. Practice, practice, show it to a lot of people, have thick skin, change it if necessary, and write the paper. And this is the last part, and this is where I wanted to talk with Yves about the paper. So a clinical research manuscript is not a review article or a book chapter. That's why they're generally limited to a few thousand words. And like abstracts and like talks, not all sections are created equally. It's not a literature review, so concise explanation for why you chose to do your study generally should always end with the purpose of our study is to, and let's take, describe the change in exercise performance after a Ross operation. You should always follow parallel construction, which is what I'll show you in a future slide. You want to order the results exactly as you said they were going to be in the methods. Another thing in a couple of papers I've read recently, you can't introduce a method in the results section. The results always are broken down by primary and secondary outcomes. You can't introduce results in the discussion section, something that you didn't have in the results section. And stay true to the purpose of our study is. All things that you measured or included in the methods must be in results. All things in the results must have been in the methods. And again, in my view, use tables and figures whenever possible. Here's an example of a parallel construction in a paper. So if we do the methods, which are who, when, how, and what. So these are the who. All patients undergoing a Ross between this period of time, which is the when. How are we going to do it? We're going to do a Bruce protocol where the primary outcome is maximum VO2 and secondary outcomes are changed from pre-op value duration, heart rate variability. The details are not important here. But your results then have to follow that. So you have to start with patient demographics. That first bullet, all the patients undergoing a Ross, you have to describe them. There they are. Then your primary outcome is the maximum VO2 on the Bruce protocol. And then you might, on your secondary outcomes, if you're looking at the change, you may want to have a pre and post bar graph or box whiskers, the duration of exercise as a cumulative sum graph, et cetera. This is where your statistician is going to help you. You want to have this in parallel construction. You don't want in the secondary outcomes to start with a perceived level of distress when that was fourth in the methods section. And these were the 7 paragraphs I was taught, Yves, and I'm curious what you say. So this is where, again, this is not a literature review. This is about your study. So the first paragraph is, we found this. Second paragraph is, others have found this. Why our study is different or the same as others, and why that's important. What's the clinical relevance of our finding? What are the study limitations? What are our next steps and conclusions? When I start to see literature reviews in the, and I'm sure Yves, you're the same way in when you edit, long discussions don't help your study. All you're limiting your clinical research thing for your clinical research paper is your primary and secondary outcomes. So that's all I wanted to talk about. I'll stop the screen share. We're about 7 minutes close to being done. And I'm open to any questions. Yves, do you have any comments on that? Because we've not worked together on this yet. So I'm curious.
I've put some little things on the paper as you were talking, just to add up to what you said. I think that the abstract that I review get rejected, and I give you some example of where I reject it. If that they have a conclusions, they may have the data, but they don't show the data in the abstract to justify a conclusion. It's out. Or sometimes I disagree with them and they're probably right, but they forgot to mention something about the characteristic of the patient. And so how do I know that they're right or wrong? So you have to think backwards when you write it. Sometimes the people have to accept about looking at the smaller things. You have to look at you, especially in retrospective study. You may have accumulated a lot of follow-up on 500 patients, but actually the one thing that is interesting is in a subgroup of 50 patients and on a parameters that was not, the one that you looked for initially, but that's new and it's sexy and exciting. Mm-hmm. You have to be ready to give up 75% of your work and concentrate on the 25% that are interesting.
Let me ask you a question on that, because we've all done that. And the question, that becomes then a sub-analysis of your original presentation. Do you think it's good to put that in the big manuscript and to say in a secondary sub-analysis we found this, or to take that data out in and of itself? I'll just close that question. What I've seen done is you write the big manuscript and the smaller one that says, this is a sub-analysis of the previously published study by blah, 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 blah.
The thing is that you should always try, but it's not always possible, to put everything in a single paper and get it to the highest impact factor. So my PhD work, where I look at the difference in the different technique, the team of, there is a team in Germany who had published the double number of patients, and their title was Long-Term Outcomes After Tetralogy of Fallow Repair. They get it in the Annals of Thoracic Surgery. Good paper, but, you know, and the graph was exact, they had the exact same graph that I had, but I titled it Late Transannular Patching equals right ventricular patching in Tetralogy of Fallow. And I get in circulation. So you know, you have to be really focus on what is interesting, the new stuff, the interesting bit.
It's like the aha slide too. Instead of having results :3, make the title of that slide what you want people to know, just like the title of the paper. I like that.
Very small, very quickly. I hate acronyms. It's a literary exercise. I have papers, entire papers, where there's not a single acronyms. And the group, when I have to go back up and forth to see what it is, this slide, I think in talks, usually I have been said by somebody, the people will remember 2 or 3 numbers. That's all. So you get your chance. There's no point in giving them 150. They're going to remember 2 or 3. Make sure that they remember the important ones. The way I proceed with the manuscript is that when I work with my younger researcher, I tell them, and it's not always done, but the right format is that when they start the study, they look at the literature research, they start seeing 5 or 7 files, for example, and I tell them, you write the manuscript in blank, the patients and methods. And so you write the patient and methods in blank, and this way you can remember, oh, when I write it, I need that data. You don't forget to collect that data. When you get your results, we do the statistics. Then I tell them, you make the abstract, and at the same time that you make the abstract, you write a first draft. Then you leave it for 3 months. And the best is when you come back 3 months later, you see how shit is what you've written, and then you go back to it. And I have a very strict rules. I help the guys to build up their slides. I build up the slide on the manuscript. They give me the manuscript to build the slides. I build it because it's very easy to build up the slides out of a manuscript. If you have to do the slides and then the manuscript, you do twice the work. It's stupid. So
there's a wonderful book out there called Bird by Bird, and the first chapter is called The Importance of the Shitty First Draft. It's very important. That's a great idea.
And then limitations. When you write a paper, I got this stuff with limitation. Between you and me, if I have written it or have supervised it, this is the fucking best work in the world, okay? There might be limitation, but they're minuscule in my mind. Otherwise, I don't do that job, for God's sake, you know, okay, no? So I said the things about the result. The best way to send the review is to say, okay, we couldn't do that, but I've put it up to the limitation. So if you start with half a page of limitation, you will end up with 1 page of limitations. You're going to have more limitation than discussion. So you always, the first draft, the first version of the manuscript you send, small limitation, 2 or 3, 4 lines, no more. No more. And then, well, if you have to add up, then you have the space to add up. But if you start with big limitation, then you're fucked. Huh? So, sorry.
I love our informal congenital heart academy. Are there other questions, Grace? For Eve, that's perfect. I'm really looking forward to starting this work with you. It's going to be fun.
We don't have a lot of questions, and I think we are a little bit late, but there's one question that is interesting. It's how do you strike a balance between you are looking at the tree and forgetting the forest, and you don't have a primary outcome?
Oh, I don't know if that's a balance. If you don't have a primary outcome, you don't have a research study. I think you have to have a primary outcome. I think that's a difference between, I hope I'm answering the question as I see it, but You can do you can collect a lot of data, but you don't have to put all of the data in one 10-minute presentation. You want to get at that primary outcome variable. When you write the manuscript, and that's why it's important to you, in my view, to use tables and figures. Not only does that shrink your text down, but you could list, I talked about the Ross operation. You could list the 5 risk factors for lack of change, adiposity and all that stuff, or you can make that beautiful box and whiskers plot. That's what's going to be used in other people's book chapters and slides and presentations. But you want to focus in your discussion, our study found, and you focus on the tree. The forest can be in other places in the manuscript and tables. What do you think, Eve? Have you?
You can say about the striking the balance of primary outcome, and so I have to confess, sometimes you go on fishing exercise. I try to avoid that, but sometimes you end up being in fishing exercise. I think that the important thing is there's a story behind it. It's always a question of finding the story. What's I look at the most exciting moment in the research between having the idea, getting the results, presenting, are still putting up a show and presenting. But the most exciting moment is when the guys arrive with the list of numbers and graphs. And then I look at it and it's fresh, and I say, where's the story? What does it tell me? And so I think that's what you have to vehiculate.
Yeah, that's different at different stages of the career. I remember when I was younger, the most exciting thing was the first time I saw Wernovsky et al. In the corner.
You quickly go over that. I got over that. I remember that too, but that's a long time ago.
The second part clearly is when your hypothesis comes to fruition, your question gets answered. And then, for my stage and probably yours, to see the work referenced and improved upon or adjusted upon, knows that we're pushing this forward, that becomes, or actually see your work referenced as being obsolete. We talked about this very briefly. I got very involved in looking at deep hypothermic circulatory arrest in the 80s. It was an important question there, not that important of a question now. However, we have 30-year follow-up on that cohort that are very finely described. Would never have thought that we would have been able to get that. So you never know which direction it's going to get. Seeing patients, and I'm sure you feel the same way in your Fontan registry, and if it's okay, I'll close with this, Grace. Seeing patients you enrolled as newborns becoming parents of their own and doing well, as Eve said, it's always about the patient and do no harm. That is the best part about a research, in my opinion, a clinical research career.
Guys, it was really inspiring. It's not only that we learned, we got inspired by all of you, and then we could see this on the chat box. People are really thanking all of you for this very nice talk, and we learned a lot. And hopefully, especially for the youngest people, they are going to be able to do much more now. Thank you very much, guys. It was amazing.
It's great to see careers advance and going into places. It's the best part of this, really.
We are very happy, and we need to do more of these. I think clinical research is something that is very important. I'm so happy, Gil, that you had this idea and introduced the subject. We need to do more.
It was Eve's idea. I just filled the time slot.
Thank you very much, guys. It was
Eve, thank you, and Grace, thank you very much. There was a question in the box, Grace. We don't have yet a time for the second portion of the transposition series.
No.
I was waiting to get together with Eve, so we're on the same page about what we're doing with transposition. So I will get back to everyone from the Academy. On the 27th is the current talk on tetralogy. Yes. I may switch the transposition talk into there.
Okay, that's a good idea. And then we move forward with tetralogy on the next one. Amazing.
Thanks, everybody.
Thank you, guys. Bye-bye.